Immediate improvement in pain relief occurs after this operation, and as long as the patient is physical therapy, we get an excellent result from this. Diabetics can recur and require it again. It can be very frustrating for them and for to get them better completely. But most of them do. It goes through an interesting natural history in that the shoulder hurts really bad and is not very stiff. Then it hurts and it's stiff. Then it stops hurting, but it's still stiff. Then it starts hurting again and it starts moving again. And then finally it stops hurting and it keeps moving. That's the whole natural history of the frozen shoulder if you wait it out 18 months to 2 years. But it's more fun just to take care of it and get your life back. But we do still try non-operative treatment because there is a healthy subset of patients, probably 30%, will get better without surgery over a reasonable time, like 6 to 12 weeks. The instability is, I'm talking now about multidirectional instability. This is a patient who has natural laxity in their capsule, not a patient who has had a traumatic dislocation, which is falls into the labral category. But there's this subset of people, they're usually swimmers, because they're pitchers, because people who have natural laxity in their shoulders are really good swimmers and are really good at throwing a ball because they get that whip out of their arm because they can hyperextend it or over-rotate it. But sometimes it becomes a problem when they're so loose that it causes a lot of inflammation and irritation of the capsule and of the cartilage in the shoulder. And they'll describe this dead arm feeling after throwing or sleeping on their arm at night because their shoulder is so sloppy, it's pulling on their brachial plexus, on the nerves that run by the shoulder that go down from the neck to the arm. And their arm will be falling asleep if they're laying on it funny because their shoulder's moving in and out of the socket. So that's a typical history from a patient that has this multi-directional instability. And as part of their workup, we look at for Marfan's or Ehlers-Danlos or a collagen vascular disease that's some sort of a systemic problem leading to this. But typically it's not, it's just that they are loose jointed. A sulcus sign and this shuck relocation test are the physical exam findings for a patient with multidirectional instability. And what the sulcus sign is, we're just having the patient, standing next to the patient, we just pull down on their arm and look right here. Like we can see a divot will occur between their acromion bone and their humerus. You'll actually see it through their deltoid when you pull their arm down. And that's a very sensitive test for having multidirectional instability. The instability or shuck relocation test is where they're laying on their back on the exam table. The examiner takes the arm and moves the shoulder in and out of the socket, and then letting go, it will relocate. Or bring the arm forward, it will come all the way back in the socket. So it's that unstable where it's dislocating, relocating very easily. Treatment for this is very difficult. Physical therapy to strengthen the muscle around the shoulders, anti-inflammatories to decrease the inflammation, modifying their activity, which is no way you're going to tell a swimmer not to swim. And arthroscopy can be an option to plicate the capsule. So it's just like reefing a sailboat or pleating a pants. We take a bite of the capsule with a little suture and just tie it down to try to tighten up this very patulous capsule that's causing the shoulder to be too loose. But it's very difficult to do this because it's kind of a feel thing. You don't want to over tighten somebody. You don't want to tighten them too much in the front and push them out the back, or in the back and push them out the front. So it's a difficult problem to treat surgically, and we do that as a last resort. But it can be very successful, and I've had good luck with swimmers. Just doing a little bit to tighten them up in the front makes a big difference. So but these patients are always living with this. This is something that they manage, not cure. So they always have some degree of discomfort. They learn how to sleep comfortably. They learn how to modify their activities, take anti-inflammatories when they need it, and do their exercises religiously to help strengthen the muscles around it. But this is a long-term maintenance type of a problem. Chondromalacia and arthritis is a big topic, and it's getting more and more common as the population is aging. We're seeing more and more of this. There's a lot of people who are petrified of surgery who've had labral problems or rotator cuff tears that have gone unaddressed, and then down the road, it's the instability and the trauma that's resulted from that they're ending up with bad arthritis and a really dysfunctional shoulder. So it's typically an older patient. They have pain with range of motion, they have limited range of motion, they have trouble getting their arm up over their head mechanically, like even if you take their hand passively, you can't get it up there, and they lose external rotation. They get a grinding feeling in their shoulder, and you can actually hear the bones grinding together when it gets bad enough, and they have typically difficulty sleeping. On the physical exam, it's loss of range of motion and this crepitus or grinding sound. The X-ray is diagnostic, obviously, for this. The MRI can also show if there's loose bodies in the pouch, which are pieces of cartilage that have broken off and floating in the shoulder. They can show the amount of degeneration. But the most important thing we use the MRI for in an arthritic shoulder is to see if the rotator cuff's intact. Because if the rotator cuff's intact, then we know that it will be successful with a traditional shoulder replacement. If the rotator cuff is torn, then we have to determine, is it a repairable tear, and if it is, then we would repair the tear and do a traditional shoulder replacement. And if it's not, if it's a chronic tear, then it's a patient that needs the reverse shoulder replacement or the other kind of shoulder replacement. So treatment, again, here's the, not hard to be an orthopedic surgeon. So anti-inflammatories, cortisone. Sometimes if it's early, these patients, unlike knee arthritis, these patients do well with arthroscopy to clean out or do a chondroplasty, which means smooth out the roughened cartilage, take out the loose bodies, take out the inflammation. They can actually do well with an arthroscopy. It's not a cure, but it can give them years of relief prior to considering shoulder replacement. And I would do that for somebody who is mild enough that they haven't lost their motion yet and they're still pretty functional. But once you start losing motion, then I think it's better to proceed sooner rather than later with the shoulder replacement. Because the longer you wait, the stiffer the shoulder gets, the worse the outcome after shoulder replacement. So it's better to kind of get them early. Outcome is usually very good. The shoulder is not as painful as the knee and about on par with the hip. So the patients are out of the hospital in a day or two. They have 6 weeks of therapy to get their full range of motion back, and at 3 months there's typically a full recovery there. So this is what an arthritic shoulder looks like. They call this the goat's beard osteophyte, and this is very typical and diagnostic for shoulder arthritis right here. And this is what a shoulder replacement looks like. The cuff tear arthropathy is the same thing. So it's a bad rotator cuff tear and arthritis. And this is where the patient's joint has worn out completely. So you see the bones rubbing together in this picture right here. There's no space between the glenoid or socket here and the humerus here. They have the goat's beard osteophyte down here. But also, if you look at this, the center of the head is migrated superiorly because the rotator cuff is gone. So it's rubbing on the acromion as well. And this is a mechanical block. So even though this patient has their deltoid muscle, which is this white squiggly line depicting, they can't pick their arm up. It's trapped under their acromion bone. So it's not only an arthritic problem, it's an instability problem because they've migrated superiorly. They're trapped. So what this scary looking thing does is get their center of rotation down. So we put the ball on the socket and put the socket on the stem. And really what it is a more constrained shoulder. The ball is more captured in the deeper soup bowl than a typical ball on a dinner plate, which is what a traditional shoulder is. And by trapping it there, by lowering it down, the deltoid becomes functional again, and they can pick their arm up with the deltoid muscle even without a rotator cuff. So that's what a reverse shoulder is, and that's really been a wonderful